ค่ะสวัสดีค่ะค่ะสวัสดีแขกผู้มีเกียรติทุกท่านนะคะก็ขอต้อนรับเข้าสู่การประชุมวันที่2นะคะของเราค่ะ Good morning distinguished guests ladies and gentlemen welcome to the 5th Thailand Elderly Health Service Forum 2025 We are honored to have you here today for the second day I am Saranya Manarungrungsin from Department of Medical Services In this morning, we have two interesting sessions. Let's begin with the first one, geriatric dentistry oral health care in the elderly to achieve 80-20. This session will explore the crucial role of the oral health care in elderly well-being. It will be moderated by Dr. Saranya Glatklao from Institute of Dentistry, Department of Medical Services. Let's give a warm welcome to Dr. Saranya Glatklao.
Thank you very much คุณสรัญญามานะรุ่งเรืองศิลป์ for warm introduction สวัสดีค่ะ Good morning distinguished delegates ladies and gentlemen and honored speakers on behalf of the Department of Medical Service this is my great privilege to welcome you all to this session on geriatric dentistry oral health care in elderly to achieve I am Saranya Glatklao from the Institute of Dentistry and I am honored to serve as your moderator for today's sessions. We are gathered here to discuss oral health, an important issue affecting older adults' well-being. We believe that the maintaining good oral health is essential in enhancing our seniors' overall well-being. This conference aims to provide comprehensive knowledge, research, current practice, and innovative solutions improving the quality of life for our aging population through better oral health care. We are honored to have distinguished speakers and experts in the field who will share their knowledge and experience with us from Singapore and Thailand. To begin our session, this is my pleasure to introduce our distinguished guest speakers. We are privileged to host two accomplished speakers today, is bringing wealth of knowledge and experience in geriatric dentistry. The first speaker who will join us virtually from Singapore, Dr. Yang Jinrong. She is a senior consultant in the Periodontist Unit, Department of Restorative Dentistry at National Dental Centre Singapore or NDCS. She graduated from the National University of Singapore with Bachelor's in Dental Surgery and Master in Dental Surgery Periodontology. She is the head of Geriatric and Special Care Dentistry Unit and the head of Oral Health Promotion and Disease Prevention under the Regional Health Service at NDCS. She has been actively involved in education outreach efforts for nursing homes and tertiary hospitals to educate non-dental healthcare professionals on assist oral healthcare procedures and research involving persons with cognitive impairment and their care partners in improving oral healthcare. And other speaker from Thailand, Dr. Nattapol Tinsatit. He is a lecturer and head of Department Family and Community Oral Health, Institute of Dentistry, Suranari University of Technology. He graduated from Khon Kaen University in Doctor Dental Surgery and Thammasat University in Master of Science Gerodontology. His specialty and interests are geriatric and special needs dentistry, dental education, and family and community dentistry. Let's begin by respectfully welcome Dr. Yang Jinrong to share insights into oral health care for the elderly in Singapore. Please give a very warm welcome to Dr. Yang.
Thank you so much for thank you so much for your kind introduction. I'm very sorry that I'm not able to join you in person for this meeting, but we'll look forward to joining you in person in the subsequent ones. So the title of my talk today is towards the 80-20 goal, and this is actually a goal whereby we hope to retain 20 teeth at the age of 80 years old. So just a brief background about our healthcare system in Singapore. So basically, the healthcare system, the public health services is divided into 3 clusters, of which National Dental Centre belongs to the SingHealth cluster, which takes care of the east and northeastern region of Singapore. So we are the flagship dental specialty centre and the largest one as well. So in the same cluster, there are other tertiary hospitals as well as primary care polyclinics that are in the same healthcare cluster as well. Okay. So I would like to begin my talk by just sharing with everyone about the global impact and also the high prevalence of oral diseases and the cost as well. So this is a cost comparison of the expenditures on treating and managing the various diseases in the 28 EU member states. So you can see that the dental disease actually cost the third highest at 90 billion pounds. And this is also one of the largest groups of people that actually suffer from oral diseases as compared to cardiovascular diseases, respiratory, diabetes, and mental illnesses. So what are the oral health determinants and some of the risk factors that will affect an individual's risk to oral diseases? So like most of the non-communicable diseases, this oral health or poor oral health would disproportionately affect persons in low and middle income strata. It is also highly preventable with very low-cost preventive measures such as correct oral hygiene techniques, conscientious toothbrushing and use of interdental aids, or mouth rinse in selected populations, regular dental checkups, and diet that is low in fermentable sugars. But despite this being highly preventable and I would say to some large extent easily accessible in Singapore, there are various enabling and also disabling processes that encourage or prevent a particular person from receiving care. So things like adverse events during childhood or growing up in a family that may not emphasize on good oral care, social exclusion, some of the hard to reach communities may not be encouraged or motivated to seek oral care. On the other end, you have certain socioeconomic factors like those in the higher income or who have higher education, they may be more motivated to seek oral care. And then all these individual and socioeconomic factors are then individually affected by the individual factors like the type of diet, tobacco, and other inflammatory responses. So I think I would like to paint a picture of the current oral disease status in Singapore, and these figures are actually from the 2019 National Adult Oral Health Survey that we have conducted and concluded. So if you look at the figures over here, actually it paints quite a grim picture on the prevalence of dental disease. So the prevalence of dental disease is about 35% for dental caries, or what you call it as tooth decay, close to 80% for severe gum disease. And out of the adults that are surveyed, so they surveyed the adults from 21 years and above, 85% of them had 21 or more natural teeth. But you can see that as it progresses on to the later years of age, like 65 years and older, this actually reduced to 35%. And the prevalence of denture wearing is 50%. So for those who are familiar with the dental literature, this DMFS and DMFT is an indicator of the oral disease status in children and in adults. So DMFS is about 25 and DMFT is about 8. So out of these adults, an average of 8 teeth were either decayed, missing, or filled. And they have also found that persons with untreated dental caries, they also have more severe or moderate forms of periodontal disease, which is not surprising because caries and periodontal disease actually share some common risk factors like poor plaque control and inflammatory components as well. Okay. So of this group of adults, they found that the risk factors for poor oral health, not surprising, more than 60 years of age, of Malay ethnicity, and those in the poorer socioeconomic classes who are staying in 1 to 2 rooms public housing, and they also tend to only visit the dentist only when they have any pain or swelling, such as an emergency episode. Out of this, they not only did the clinical examination, they also did a survey amongst the participants. And you can see here, there's a widespread inaccurate perception of oral diseases. So about 2/3 of them felt that tooth loss is natural for old age, and they don't realize that it is usually part of periodontal cause of periodontal disease or also extensive caries. So there is this perceived inability to control tooth loss there. Okay. So out of the oral health habits, 42% of them floss once a day, and only slightly over half of them visit the dentist at least once a year. So in terms of the gap that we have in correcting these perceptions and practices, we have quite a long way to go. So I would also like to talk about the oral health in primary dentition and why is it so important. We realize that in us wanting to achieve 20 healthy teeth at 80 years of age, the efforts cannot come when the person is 65. It has to start way earlier because oral disease is a slowly progressing and also a cumulative kind of disease trajectory. So the primary, if persons have poor oral health when they are children and when they are very young, they tend to have increased risk of poor oral health in adulthood as well. Okay. So this was a recent survey. I think it was in 2022 or 2023. So they surveyed about 1,000 caregivers who were attending the KK Women's and Children's Hospital, which is one of the largest maternity hospitals in Singapore. So out of this, 10% of the infants, and they define the age as under 1 year, were given sugar-sweetened beverages, and the common one would be fruit juices. Okay, and 100 children of these caregivers surveyed were distracted with digital devices during meal times. And why would we as dentists be worried about it? Because they tend to overeat and they tend to also snack on unhealthy foods as they ignore their own satiety cues. Okay, so you can see that not surprising, there is a high prevalence of early childhood caries that is mirrored in the adult population as well. So this was a study that was performed in 2009. So this is almost about 16 years since the inception of this study. And the caries prevalence is 50%. And again, we see the same modeling whereby a small percentage of the population actually carries a high disease burden. So over here, 16% of children with high caries activities actually carries about 80% of the carious lesions. Again, you can see it mirroring in the adults as well, that rampant caries is more common in Malays and males. And by the time they enter kindergarten, which is about 5 years old here, 1 in 2 children will suffer from tooth decay. Okay, so why is there a significance of oral health of achieving oral health in the primary dentition? So not only does it affect the eating function, also self-esteem of the child, there is also an impact on the permanent dentition, such as development and eruption of the permanent teeth. And the child may also be more likely to miss school because of urgent or emergent dental conditions. But I think more importantly, over here is that there is a lifelong risk that this child would carry on into adulthood. So children with early childhood caries are 3 times more likely to develop dental decay caries in their permanent dentition. So I think that's something to note. In our goal to achieve 80-20, the focus should also be to other of the younger age groups as well. Okay. So they have also noted that this early childhood caries is attributed largely to lifestyle habits and also barriers to access care. So detrimental behaviors like prolonged breastfeeding, bedtime bottle habits, that means not weaning the child of the bottle use at around 6 months. Dietary habits, frequent intake of foods high in simple sugars, so like snacking, and also the caregiver's dental awareness or knowledge and how to guide the child in performing good oral hygiene, that is also lacking. Cultural characteristics and also barriers to dental care. And we see that there is a very strong shared risk factors that the entire family unit will also share together with as the risk factors for poor oral health. So again, other than the detrimental behaviors specific to childcare, the rest of it actually is these are shared risk factors between the child and the adult. So since then, there have been some changes to the oral health or the public health landscape that is relevant to dentistry. So the first one would be the sugar labeling. So we have not gone down the road of sugar taxation, but sugar labeling is currently implemented in the snacks and also drinks that are sold in supermarkets and also in the food stalls in Singapore. So this is to drive certain corporate and individual behavior to manufacture and also to sell and select healthier products. So we know that Singapore is a very great obsessed country. All parents want their kids to score A's. So very rightly they have put the one with the least sugar as A. So everybody would want to gravitate towards that. So I think it's a form of behavior model that they're trying to advocate. And over at the corporate side, what have they done? They have actually prohibited or the advertising of any food and drinks that is high in sugars that is labeled as D in the manufacturer's side. So I think it does drive certain industry behavior to manufacture the healthier options as well. And the next one would be smoking cessation. So we have actually taken steps to incorporate anti-smoking or tobacco messages in schools and also institutes of higher learning. We find that some of the high-risk individuals actually start smoking in secondary school, even though the minimum legal age is currently now at 21. There's also surveillance on tobacco retailers to increase the penalties and possibly revoke the license for sale. So the smoking cessation campaign, we have seen some small successes, such as you can see that in 2020, from 2021 to 2023, there is a reduction in the prevalence of daily smoking. But I think now the new kid on the block is vaping. So currently, it is illegal to vape, but we know that on the ground, it is very difficult to police and to institute these prohibitive sales measures for vaping. So this is a space to watch. And another one that is relevant to dentistry or maybe pediatric dentistry would be this initiative, Grow Well SG. So this is a national initiative, also launched recently on the 21st of January. So this aims to empower families to ensure that children have good dietary, sleep, and exercise habits. So for dentistry, I think the good dietary habits would be relevant to us. And this is also with support from preschool, schools, and healthcare institutions and the community. Because we know that the child doesn't just exist in silo. They exist with caregivers. The caregivers exist with schools and also preschools as well. So this is also an space to watch as well. Despite all these public health policy changes and improvements, we still face certain challenges in oral disease prevention. Number one that I mentioned earlier, there is a very big gap in the public knowledge on how to prevent and take charge of their oral health status. Number two, in Singapore, we are also encumbered slightly by the manpower cost. So we have more dentists than allied health professionals to support us. So for allied health professionals relevant to dentistry, this would be people like our oral health therapists. So this will increase the cost of any preventive oral health programs. Thirdly, is the financial remuneration for dental professionals. It is still largely a fee for service, especially in the private practice where majority of the dental professionals are. And we also note this 40-year gap in preventive services that reach out to those in the 18 to 65 years old. So the school dental service will cover persons up to the school-going age, which is 18 years of age. Functional screening takes care of seniors from 65 years. So that there is no national initiative that takes charge of working adults and the young adults as well. Okay, and currently oral health, we have not been onboarded onto Healthier SG, which is also another national initiative to drive the healthier behaviors and hopefully to reduce the disease burden of chronic preventable diseases like hypertension, hyperlipidemia. Okay, so in view of all these challenges, that we have implemented certain health strategies at NDCS, which is to partner some of the non-traditional partners as well. Okay, so we understand that just by clinical prevention education, that means chair-side education of the person, we can only achieve limited short-term effects and only can benefit those that reach us at the dental chair. So there are certain high-risk populations that cannot be reached, and we have taken some steps to identify them. Using some complementary health public health approaches like disease prevention and also sugar labeling, like creating more supportive environments to allow the practice of good oral health and working with non-traditional partners. So we have taken a life course approach to population oral health, of which it is all in the drive to achieve the 80-20 goal. So we understand that the first 1,000 days of life is most impactful to the health outcomes. So the infant oral health program has been launched. I will share more about it later. Maternal and child is something that we have not yet started, as well as the young adults to working adults. We have also embarked on initiatives to benefit the seniors, such as the oral health movement 80-20, functional screening, and the teledentistry. So I will share more about all these initiatives. So for the pediatric population, what have we done? We have actually engaged healthcare partners, and I mean healthcare partners in a sense that they need not be healthcare professionals, but even community partners that are relevant to the health of the child is included as well. So really, it's empowering the child's village, like the preschool teachers, community nurses, and for parents, there is an integrated health social hub that will provide parents with the resources such as oral health education to teach them how to brush the correct way for their children. Okay. So the other one would be risk profiling through screenings that are done by non-dental healthcare professionals. So this is actually making use of touch points with the child, home, the preschool, and also mandatory health screenings that the child goes through up to 18 months of age. So we have like the lift the lips KV screening for 1 to 3 years old, and also the open wide screening for 3 years and above. So this is really just a visual check, and with that, the needs of the child is also triaged, whether to see a dentist or to see a specialist. So for the community dwelling older adults, I will touch on it. So why are we focusing our efforts on the community dwelling older adults? We understand that oral frailty will actually impact on a person's ability to chew, swallow, and speak. And it is a predictor for physical frailty and dependency and mortality amongst these older seniors. And when there is any interruptions or deficits in terms of the nutrition and also the mobility, it can also result in sarcopenia as well. So over here, this is a local study that is done in a township in Singapore, Yishun. So they have found that 1 in 3 Singaporeans aged 60 years and above actually have sarcopenia. And even in the population that is younger than that, there are still people suffering from sarcopenia, 1 in 14. And untreated dental caries is amongst the most common dental condition that often affects the adults with oral frailty. Okay. So we have implemented this screening for oral frailty, and these are used in some of our health carnival outreach to the community as well. And the questionnaires are actually also able to try kind of profile the person according to the risk factors. So over here, these are the 8 questions that are being asked. So the importance of 20 healthy teeth, why the number 20? So this started off with the Japan 80-20 campaign, whereby they have found that having 20 teeth at 80 years of age were associated with better diet and nutrition, physique, and lower risk of gum disease. So they took about 40 years to reach from 9% to about 51%. So over in Singapore, in 2017, this was a representative survey, national representative survey on community dwelling elderly. We are at where Japan was in 1979. So only 9% actually was able to reach the 80-20 goal. So we have some room to grow in this aspect. And this actually led to the inception of the oral health movement 80-20. Okay. So how do we implement this? So previously I had touched on the challenges in that we face in the oral healthcare prevention. So partnership with healthcare providers and community partners is one of the keystone in this oral health movement 80-20. So this actually we have actually reached out to community nurses to teach them how to perform a basic oral screening for the elderly, and besides that is to follow up with them for the dental care. And not only that, it's also empowering them with the oral health knowledge on how to brush the correct techniques. Okay. So these are the some of the oral education brochures that were actually produced as part of the campaign. Okay. So the progress of this exercise, we have outreach to about 295 participants, of which about 12% of them are at risk of oral frailty, and about 88% of them are orally healthy. Okay. The future plans for the oral health movement 80-20, we hope to actually involve more stakeholders such as the active aging centers and also Health Promotion Board in order for the program to be more sustainable. And we are also incorporating this questionnaire into the Health Buddy app, which is an app that patients in SingHealth would make use to make appointments and so on. So this is actually a way for them to self-administer the questionnaire and find out their risk profile, and also to monitor for changes after they seek the dental treatment. So the OFI-8, which is the Oral Frailty Index questionnaire that I shared with you just now, is also currently incorporated into the ICOPE screening. So ICOPE is actually this program by WHO, which is the Integrated Care for Older People, and they have got various domains like cognition, hearing, vision, and locomotion. And they have WHO has also recommended for oral health screening to be incorporated into ICOPE, of which they have these 3 questions that they have selected to be representative of the OFI-8. So the next one is actually this project Silver Screen Dental Functional Screening. This is funded by the Ministry of Health. And what this does is that there are community nurses that conduct what they call the level 1 screening on 3 domains: vision, hearing, and the oral function. So they have reached out to about 46,000 seniors at the level 1 screening, which is done by community nurses. Then after the screening, they have referred close to 10,000 seniors for level 2 screening. So this is actually done by the dental professional, and they will then evaluate whether there is a need for dentures. Okay, so they have about 50% that is indicated for dentures. Okay, and this is still an ongoing program that is currently in the talks of moving on to the private dental clinics. So the results from Project Silver Screen, we have published. Mainly, this one is actually to investigate whether the number of functional teeth and functional occluding units, how does it impact the oral health quality of life. Okay. So over here, these are some of the raw data on the prevalence of caries, periodontal disease, and the average number of remaining teeth. Okay, but they found that interesting finding is that dentures did not fully restore the quality of life, even if they were well made technically. Even if they were technically satisfactory, it did not fully restore the quality of life in these seniors. So I think it's really something for us to, as dental healthcare professionals, to know is that really prevention of tooth loss is still one of the key ways to ensure a quality of life in the later years. Okay, so we have also partnered with the dementia daycare centers to provide oral health education for caregivers. So what we hope to do is actually, through this oral health education program, evaluate the knowledge and skills of caregivers and also understand more about the oral health status of individuals with dementia as well. Okay, so these are some of the ways that we are partnering with the community partners. Okay, so we also have oral health programs for homebound and institutionalized persons as well. And over here, I think it is also good for us to be mindful that the aims of the programs here may not really be to achieve the 80-20 goal, because in this vulnerable population, very likely they would have a greater rate of tooth loss already. So the aims of the program is actually crafted quite differently from the other populations that I've gone through previously. So the first one would be to reduce the rate of any unplanned dental visits due to dental emergencies. The second one is actually to reduce the rates of aspiration pneumonia, which often presents in this population because of other comorbidities like dysphagia and neurological degeneration. And we also hope to improve the access of care through tele-imaging and also right siting of basic care to our allied health professionals. So here we have leveraging on tele-dentistry to improve the access of care to homebound seniors. So we have recruited about 7 nursing homes and community partners who will conduct the home visits. And we have found that, just at 6 months, about 42% of the dentate seniors have new caries again. Okay, so there is a need, to frequently monitor these adults, but through what means we are still exploring, but likely a mix of physical visits by the dentist and also the use of tele-imaging services. So the findings for TDOCS, you can see that compared to the National Adult Oral Health Survey, a more frail population in general. Okay, so about 85% require some form of dental treatment. Okay, so we are also expanding the job scope of our allied health professionals, the oral health therapists, to provide basic dental care to these group of seniors. So they have lower cost of training and also lower manpower costs to allow us to sustain these programs. So we are looking at the right siting of the basic dental treatment to the oral health therapists. And what they can do also is to educate the staff in the long-term care homes on assisted oral care procedures. So this will actually free up the dentists to handle more complex procedures that these population may face. Okay, so currently the job scope of the oral health therapists would include fluoride application and also scaling. So with the training, we hope to also add in like extraction of loose teeth at risk of aspiration and also fillings for these. So the training is actually conducted by special care dentists and also other relevant specialists from the center. So for the long-term care homes, we actually provide a holistic care model of both arms, so the prevention arm and also the intervention arm. We have the oral health education program which is to basically educate the non-dental healthcare professionals like nurses or nursing aides to deliver basic oral care and oral hygiene for these group of persons and also to identify common dental conditions. Then the intervention would be the mobile dental clinic that we are hoping to launch in April this year to provide basic dental treatment to the seniors. Okay, so these are some of the objectives of the OHAP program, which is the education program. So we go through like the etiology and pathology of dental diseases, how to detect and what can the nurses do in terms of like simple oral pathologies and the procedures for comprehensive oral care for adults that require assistance. So also we have worked to actually reduce the number of like physical contact hours to run this program. So it's both a win-win situation for the dentist and also for the persons in the long-term care homes because they often face manpower challenges. Okay, so we have a hybrid model. We have a hybrid model whereby we have the online modules and then physical face-to-face session of about 2 hours to go through the practical aspects. Okay, so we are also doing studies. So this study is actually run by Prof. Marco to basically assess the effectiveness of this program in reducing the risk of pneumonia amongst these residents in the nursing homes. Okay, so just now I touched upon the mobile dental clinic. So this is currently planned to be manned by dentists, but in future, once the oral health therapists have been upskilled, the operations will be transferred to them. So I will touch on a few future plans, which is touching on prenatal and also working adults. Okay, so this is a group that we have alluded to earlier. We have not really touched on. So prenatal and antenatal oral health is something that I think is not really heavily emphasized currently to mothers and to the obstetricians as well. So there is a vertical transmission of the oral microbiome from mothers to child, and this can be through the placenta during the antenatal period, delivery, and also breastfeeding when the mothers are in close skin-to-skin contact with their babies. And untreated dental caries in mothers can also increase the child's risk to dental caries. So we really want to get everybody at the right starting point or reduce this inequality that that some of the children are facing. And the most receptive period for anyone who's gone through pregnancy is actually of any mother to instill or better their healthier lifestyle habits would actually be during the point where they are carrying the child in their womb. And the motivation is innate. Every mother wants the best for the child. So this is also the most receptive period, and where they also have regular touch points with various healthcare professionals. So we feel that this is a golden opportunity for us to intervene. So potential areas that we can have to improve the awareness would be through social media campaigns, because mothers are likely young, savvy with the internet, social media, and this is where we can actually educate them on the importance of good oral health. If you haven't seen a dentist, do see one before the delivery of a child, because you'll be very busy subsequently on, and that's when also the education of how to care for the oral health during infants, even before the first tooth is out. How do we take charge? So as a mother of three, this is something that even I wasn't really aware of until I actually spoke to my pediatric dentist colleague. So really, this awareness amongst the public and the healthcare professionals. So we can also potentially partner the midwives and the obstetricians in identifying the high-risk individuals to institute dental screening and treatment. Okay. So the next group I have is the working adults, and specifically here I say the high-risk working adults. What are some of the challenges that we face? So often the education or the knowledge aspect may not be the most challenging, because they are on social media. The education aspect, campaigns can improve their knowledge, but often the practices, why they are not able to institute the practice, because usually they are also challenged by other life priorities. So the working adults is a very special group. They have usually caregiving priorities either to their young children or to their aging parents. Financial limitations may be one, because when you have more dependents, the dollar is being stretched. And also the last thing is that they may not have fully experienced the burden of chronic disease. So perhaps they have not experienced tooth loss. They feel that they're still having a full set of teeth. They're able to bite and chew. And often as they reach to the like 50, 60 years of age, that's when they start to experience the effects of them neglecting the oral health in the earlier years. So ways to overcome it. We can actually incorporate oral health messages into the caregiving of young children and older adults. So basically, it's to treat this group as a family. So as a family, you will experience and you will share certain common risk factors, such as the access to care and so on. So it is really addressing these risk factors as a whole family unit, and also potentially partnering with non-traditional healthcare partners. So Healthy Families, Healthy Smiles, this is a family-based approach to preventive oral health. And this will be, we are running the first run in March this year. So we have partnered with grassroots organizations to reach out to the at-risk families, because usually the grassroots organizations will be involving them for other programs like reading programs, how to read to your child and so on. So we are also tapping onto their network to reach out to the at-risk families. And we hope to actually support them, especially those with less resources, to build a good foundation for their subsequent social and oral health outcomes. Places of worship, Also, something that we have not yet explored, but really keen on exploring, is because we understand that places of worship bring people of diverse backgrounds together on a regular basis, and hence this is actually a good place for us to engage either the religious leaders or the people to disseminate some of these oral health promotion messages. Workplaces would be one, because I think in Singapore we have one of the longest working hours, and the amount of time that a person spends at the workplace is proportionally quite high as well. So what can we do would be to whether we can work with them to cut down the usage of sugar in the staff canteens, giving them time off for their annual dental checkups, and possibly including dental benefits as part of the employment package. So with that, I will conclude my talk. So some of the learning points that we have is that 80-20, this goal really starts from young. It is too late by the time we intervene at 65, because and we know that the first 1,000 days of life is really the most critical for good health outcomes. We have also noticed that there's a big disparity gap between 18 to 65 years old, where oral disease prevention takes a back seat. We are currently looking at leveraging at public policies, healthcare policies, and non-traditional partners, and also technology and the right setting of care to ensure that the manpower and financial practices are sustainable for this in the long run. And with that, I thank you all for your attention, and happy to take any questions.
Thank you very much, Dr. Yang, for your enlightening presentation. Now we have a perfect moment to ask any questions you may have regarding the topic. We now open session to questions. If you have any questions, please feel free to ask her. Okay. From your presentation, I will have your situation in Singapore. Oral care is not different in Thailand. We have a carie problem in childhood, periodontitis in adult, and tooth loss in elder people. Yeah. And we really admire the in oral health care program that from the childhood until the elderly. So maybe I have some questions.
Yeah, sure.
Okay. Could you explain what the procedure that a dentist can do in mobile dental care?
Yeah, so it is basic dental treatment such as like simple extractions and simple restorations that do not involve the pulp or close to the pulp, and also the some simple scaling for persons that can tolerate that. So meaning like for persons with dysphagia, they may not be good candidates for the traditional scaling that we do involving water. So the mobile dental clinic concept is actually we will be running the screening for all the participants first. So screening in the sense that will give us an idea about the oral healthcare needs of the persons. Then based on the screening results, we will then kind of structure their care. So meaning that in the screening, if we realize that okay, we may need to liaise with their medical physicians on certain precautions like stopping of blood thinners and so on, then this will be done before they are seen on the mobile dental clinic. So the physical screening is done at the nursing home, either bedside or with a portable dental chair.
Okay. And about mobile dental care is for the elderly or another people?
It's for persons in the nursing homes. So it can be it's largely elderly, but we also have adults who are slightly younger than that who may be socially destitute, and they are also in the nursing homes. But basically, it's a vulnerable population that will have impaired access to care.
Okay, thank you. Any questions from the floor? Okay. 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 Thank you very much, Dr. Yang. Again, your expertise in the field of elderly healthcare has provided us in a clear vision for the future oral care for the older adults. Please, thank you again for the Dr. Yang. Please
thank
join
you.
me in expression our appreciate with a big round of applause. Thank you.
Thank you.
So now moving along to our next speakers. I am honored to invite Dr. Nattapon Thinstit to share insights into oral health prevention and promotion for the elderly in Thailand. Please welcome Dr. Nattapon.
สวัสดีครับ Thank you for introducing me. Good morning, ladies and gentlemen. I'm really glad to be here as speaker. Today, I will present the concept of 80-20 that Dr. Yang had shared for you in the previous presentation. 80-20 for better quality of life in elderly people. First of all, may I introduce my workplace a little bit. I work in Suranari University of Technology in Nakhon Ratchasima province. Usually spend 3 hours and 30 minutes from Bangkok to this province, and they have a lot of tourist attraction in this province. Okay, without further ado, my topic today is the concept of 80-20 for elderly health and well-being. Everyone had know the concept from Dr. Yang, and today I will describe more about this concept and what is the importance of this concept. And second topic is oral care for other people. Oral care is main key of maintaining our oral hygiene and linked to be our general health and oral health as well. Okay, let me start with this slide. Many people believe that tooth loss is related with aging. However, tooth loss is not natural process of aging. We can keep our teeth until we die. The cause of tooth loss from untreated oral disease such as dental caries or tooth decay and periodontal disease or gum disease. This is two major disease in oral cavity that cause of tooth loss in many people. A systematic review and meta-analysis show that the number of tooth loss of people is related with the severity of quality of life impairment. Not only the number of tooth loss, but also the location and distribution of missing teeth can impact to the quality of life as well. So, tooth loss is a worldwide issue. There are many countries try to solve problem, as Singapore or Japan. In 1989, Japanese government initiated this campaign, 80-20, for aiming a healthy and long-living society. They have 4 strategies for reach this goal by building public policy, creating supportive environment, developing personal skill, reorienting health service, like Ottawa Charter. The rationale for 80-20 campaign, if people can keep at least 20 functional teeth at the 80 year, they have effective chewing, they can get a variety of food and maintain their nutritional status. All of this can link to their general health and well-being. So this is important that of the campaign of 80-20. That's why they use this number, and 80 and 20 is the goal. 80 is everyone should have lifelong living. The average age should be increased. And next, I will describe about what is the 20. 20 is comprised of full anterior teeth or front teeth from upper left to lower left, from upper right to upper left canine and lower left canine and to lower left canine is equal 12 teeth, and partial posterior teeth partial posterior teeth at least 8 teeth. So this is the meaning of 20 teeth. This is an example of people who have at least 20 teeth. Professor Kaiser has defined this condition as a shortened dental arch, or SDA. He found that if people have 3 to 5 occlusal units, people can still have a good quality of life. Note that premolar with premolar is 1 occlusal unit, and molar with molar is equal to occlusal unit. So if you have full front teeth and partial back teeth or posterior teeth, sometimes we don't need to do anything in their mouth, don't need to make a prosthodontic treatment or danger in this patient. Okay, more than 30 years in Japan, such an implement of this policy, we can see the increasing percentage of people who have at least 20 teeth since 1993 to 2022. Such very interesting outcome in Japan. So in Thailand, we bring this concept to set a goal of dental public service in Thailand that people should live at least 20 teeth at 80 years. This is the goal for 20 years in Thailand. However, from the last state National Oral Health Survey in 2023, we found that people 60 to 74 years in all areas have lesser than 50% that having at least 20 teeth and 4 occluding pair. Moreover, in age 80 to 85 in all areas, is very low percent, only 15% that having at least 20 teeth and 4 occluding pair. It seems to be a big challenge in Thailand. And the next question, how to get or reach this goal of 80-20? I have 2 key success factors. First is oral care. Oral care is very important to maintain our oral hygiene, a link to our oral health and general health as well. And next, oral health promotion. Dr. Yang had described how to promote the health, many strategies. You can use a lot of strategy to make oral health promotion, such as Ottawa Charter, determinant of health, common risk factor, many things. Or you can use life course approach for make to reach the goal. When we focus in elderly groups, we found that every older person is different. Some have the level of functioning of 80 years, but some require full-time assistance for basic everyday tasks. So if you want to make an oral health promotion, you should classify or divide elderly people in many groups, such as if they have a well condition, you should approach as a whole population. If they have more complex condition or have early stage of disease, you should approach as an individual approach. When we see this picture, you can see each time of our life has different needs. So they may relate with the factor that influence to our health and oral health. If you want to get 20 teeth at the 80 year, you should have good oral health from childhood and maintain it along your life and to end of the life. From the fastest changing population in the world and in Thailand, we can face our patient condition like that: frailty, mobility limitation, bedridden, polypharmacy, cancer patient, cognitive impairment, behavioral and psychological problems, end of life, terminal ill, like that. It's very difficult to deal with this patient. This is my case that use a lot of resource to taking care of them. We use many people to help this patient. That's why the importance of oral care. Moreover, we found that some patients need to use oral nutritional supplements or ONS. Usually, when our patients use ONS, we use as a sip feed. We found that the high frequency of eating is related to the dental caries. The high frequency of eating is related to dental caries. If you have many times of feeding, so you have a higher risk of dental caries in the patient. Moreover, if they cannot maintain their oral hygiene, it may cause of aspiration pneumonia because it have a common pathway in this area. The patient will aspirate the food or germ in the mouth into the respiratory tract and the cause of respiration pneumonia. Aspiration pneumonia is a big issue in elderly people because it leads to be a bad consequence or death. So, oral care with brushing and removal of poorly maintained teeth can prevent aspiration pneumonia. This is the case of aspiration pneumonia in the hospital that have tongue coating. And this is my case that physician sent to dental department for seeking the source of infection of this patient. When we see in the first patient, we can see poor oral hygiene and tongue coating. So it's may possible cause of the infection in this patient. There are many studies show that people who have 10 or more natural teeth and have periodontal probing depths or gum depths usually is the space between teeth and gum. The normal depth is about 2 to 3 millimeters. If patients have more than 4 millimeters, they have shown greater risk for pneumonia. In the edentulous patient or patient who don't have any teeth in the mouth, we call edentulous patient. But they present the tongue coating. It has been identified as a risk indicator for aspiration pneumonia as well. Moreover, if our patient use denture and wearing the denture during their sleep, it's a double risk for pneumonia in very old person. So oral care is very important for elderly patients, especially dependent patients. And next, what is the mouth care, oral care, or mouth care? Not only toothbrushing, but also remove residual food in the mouth, tongue brushing, oral swab, and mouth rinse, and applying moisturizer at lips and oral cavity. This is the meaning of oral cavity that I will describe today. Health Education England launched the mouth care method for guiding hospital healthcare to provide oral care in the hospital patient. This is a barrier for oral care of the patient in the hospital, such as time. Sometimes it's not appropriate time for doing oral care in the patient, such as after wake up, because in that time the patient mood is not okay for do anything in their mouth, and patient factors, staff factors, and knowledge. This is barrier. So the component of oral care is oral care equipment, place, technique, timing. For the tool, having the right tool for mouth care on ward. First, the small head. Why we choose small head toothbrush? Because in some part of oral cavity is very narrow. So if you use the small head, it's very easy to insert the toothbrush in that area. Second is toothpaste. We should use non-foaming toothpaste, but now in Thailand we use a lot of brands that have non-foaming toothpaste. You can see SLS, no SLS, sodium lauryl sulfate in the box of toothpaste. Why we should use non-foaming toothpaste? Because foaming from the toothpaste can is one of stimulator to gag reflex of the patient. Moreover, some patient can irritate from the chemical ingredient in the foaming toothpaste. In oral cavity of the elderly, very thin and very easy to damage. And next, dry mouth gel. We found that many patients have a dry mouth from their condition or from medications. So you should have oral moisturizer to solve this problem of dry mouth. And if our patient have denture, you should label the name at the denture pot. And this is examples oral care set in the ward. The pink brush is a tongue brush for brushing the tongue, and the blue and the small blue is a brush for brushing space between teeth. Because sometimes the normal toothbrush cannot clean in this area, and this is cotton oral swab for cleaning the mouth, and this is oral moisturizer. This is cleaning water for washing the brush. Where is the good place to provide oral care? Any place that familiar with our patient, comfortable and no distraction place, such as bathroom, dining table or bed, anywhere. Before making oral care, we should assess our patient. We should screening from the outer part to inner part. From the outer part, lips should be pink and moist. Tongue should be pink, moist and clean. Teeth don't have any broken or loose. Gum should not present the bleeding, because bleeding is sign of inflammation of the gum. And next, cheek, palate, under tongue should be clean, saliva present, look healthy. If our patient have denture, should be clean and comfortable. It is very important that both denture and mouth are clean daily. Light source is very important for better visibility when we want to assess our oral patient. This is mouth care assessment for health professional in the hospital for approach to the patient. They have a picture and text for describing patient condition. Moreover, they have a color for labeled the agency for approaching. Pink is normal condition. Yellow is approach as a dry mouth care, and red is should refer to dentist or doctor. It's very useful for non-dental professional to assess the patient mouth in the ward and communicate and approach to the patient. Very useful. You can download in Mouth Care Matter in 2019. So I had problems about carrying this patient. So if our patient don't allow to make oral care, you should check. Our patients are in pain, feel unwell, confused and disoriented, care-resistant behavior, or they perceive as a treat. This is 5 checklists before making oral care. Moreover, communication is very crucial for the patient. If you cannot communicate with our patient, I have trick for communicate with the patient, especially patient who have dementia or cognitive impairment. You should use 5 C, such as calm, consistent, concise, concrete, and clear. This is a tool for communicate, and this is distraction tool for distract patient because when they don't focus in the mouth, we can make oral care very easy in the mouth. Okay, how to prevent the aspiration during the oral care? You should adjust the bed inclination between 30 to 60 degrees. This inclination can prevent the aspiration in the patient during provide oral care. This is step for brushing tooth. First, we should remove residual food in the mouth by gauze strip, or use a big cotton or a swab, and hold the tongue brush like a pen. If you hold the brush like a pen, it's very easy to change position and direction of the brush. You should not change the body position of your body position. I will show in the video later. And next, brush the teeth in the easiest position first, and posterior area such as lower teeth in the posterior area is very easy to stimulate gag reflex of the patient. If our patient have gag reflex, they may resist the oral care in the ward. This is the picture of brushing in the patient. Don't forget to brush the tongue, and this is the space between teeth. We should clean this area. If patient need to use fluoride toothpaste, this is a normal concentration. But Thailand, now we have 1,450 ppm fluoride toothpaste concentration. You should use a small pea size. The direction in the toothpaste box label at green pea size, but in Thailand use ถั่วเขียว green pea size is not ถั่วเขียว green pea ถั่วเขียว is like a mung bean, something like that. It's not enough for use this concentration, so you use like a small pea size. Moreover, some patients want to use a high fluoride concentration. This concentration will described by dentists. You use as a smear at the bristle of the toothbrush. Okay, be careful of use accessing water or saliva in the mouth. Usually in the ward have a suction. You can use suction for suction the saliva or water in the mouth, because if they have accessing water or saliva in the mouth, is risk of aspiration of the water. If you don't have any suction, you can use cotton strip or cotton roll to absorb the saliva. Okay, and next, this is a video for caring special need patient, especially patient who have difficulty swallowing. Okay, this video is Thai. However, I will stop and describe in English later. Okay. Oh, sorry.
การแปรงฟันปรับเตียงผู้ป่วยให้อยู่ที่ 30-45 องศาเพื่อป้องกันการสำลักดูดน้ำลายในช่องปากออกก่อนเริ่มทำความสะอาด
Okay,
ช่อง
stop
ปาก
please. Okay, thank you. It's very important. What is this? This is open wide mouth rest. This is tool for stabilize the jaw patient, because if patient don't allow to do anything in their mouth, they will close their mouth. It's very difficult to making oral care or other procedure in the mouth. If you don't have open wide mouth rest like this, you can wrap the cotton strip in the toothbrush and use for stabilizing the jaw. Okay.
งดการใช้ไซริงเพื่อฉีดน้ำหรือน้ำยาใดๆในการทำเมาส์แคร์ให้ใช้ก๊อซชุบน้ำเกลือหรือน้ำสะอาดบิดหมาดพันนิ้วหรือก้านพันสำลีพันก๊อซ
Avoid to use syringe to inject the water to water to the mouth. And wrap the gauze strip in your finger for with the mouth.
เช็ดทำความสะอาดเยื่อบุช่องปากและเพดาน
And if you say excessive water or saliva, you should
โด
suction.
ยยังไม่ต้องใช้ยาสีฟัน
For the first step,
ซับหมาดอย่าให้มีน้ำหยดและแปรงฟัน
use only water for brushing tooth.
เริ่มแปรงจากฝั่งที่เข้าถึงได้ง่ายก่อน
This is the easiest part of the tooth. Let's begin with this part because very easy to clean, to brush. And hold the brush like a pen. Very easy to change position and direction of the brush.
ดูดน้ำลายระหว่างการแปรงฟันเป็นระยะ
Very easy to change
ด้าน
position.
ลิ้นของฟันกรามล่างเป็นตำแหน่งสุดท้าย
And this area you should brush in the
ที่สุด
end of the end step because easy to make a gag
ระ
reflex.
หว่างแปรงฟันให้หมั่นล้างคราบต่างๆออกจากแปรง โดยอาจมีแก้วน้ำวางไว้ 2 แก้ว เพื่อคอยทำความสะอาดแปรง
You should keep moist brush all times because to prevent the excessive water in the water.
ด้วยเพื่อกำจัดคราบจุลินทรีย์บริเวณ
This is example of proxa brush
มากกว่าหรือเท่ากับซอกฟัน
that use cleaning between space
ซอกเล็ก1 ด้านสำหรับ
to space.
หลังกำจัดคราบจุลินทรีย์เสร็จ บีบยาสีฟันที่มีฟลูออไรด์ปราศจาก SLS ประมาณ 1 เม็ดถั่วลันเตา หรือเต็มตามแนวแคบของหัวแปรงสีฟัน
And then use fluoride toothpaste apply in all the
แปรงด้วยยา
teeth.
สีฟันเคลือบทุกซี่ทุกด้าน วันละ 2 ครั้งเป็นเวลาอย่างน้อย 2 นาที
Brushing 2 times at least 2 minutes. And use the same procedure.
ทำความสะอาดช่องปากและยาสีฟันส่วนเกิน ไม่ต้องล้างน้ำออก
And change the position of oral care. Change side. For this part should is the end step of brushing. And if you see excessive water saliva,
ป่วยด้วย
you should
ทุกครั้ง
suction.
โดยชุบน้ำเกลือสะอาดซับ
This is a tongue brushing. If you don't have tongue brushing like this, you can use normal toothbrush for cleaning the tongue patient.
และดูดน้ำลายขณะทำความสะอาดช่องปาก จบการทำความสะอาดช่องปากด้วยการเพิ่มความชุ่มชื้นภายในช่อง
And the end step,
ด้วยน้ำมันทาบริเวณเยื่อบุช่องปาก
use oral moisturizer for applying the lips. Okay. So oral care and oral health promotion is very important to our patient because we want to see our patient have happiness, well eating, sleeping well, normal excretion, comfort and dignity. Let us all do it and use a seamless continuum of care. Thank you very much.
Thank you, Natapon Synthesis, for your enlightening presentation and sharing your knowledge with us. Okay.
Please feel free to ask question.
Yes.
Can
We
มีใคร
have
ถามไหม
time
ครับ
for one or two questions. Or if you're not a question, maybe you have share your insights or
Yes.
discuss the challenge or opportunity in geriatric dentistry.
yes.
You can share with us.
Some people said that can I ask in Thai question or
Okay.
I think
Okay. If not questions from the floor, maybe I ask
yes.
you. Okay.
Yes.
What are some strategy for to handle difficult patients? From your videos, we see the patient remains still laying down, but in the real situation, maybe the patient is not still laying down, but it have a hard to manage them.
Okay. First, we should understand what is the difficult patient. It's may difficult from their condition or difficult from our mindset. This is very important to understand our patient. If you understand all of spec of this patient, you can appropriate approach to this patient. I think communication is very important to deal with patient and caregiver. I use a lot of strategies such as change a technique, change environment. Environment is very important. If have a lot of distraction things or noise, they can distract our patient to interest the distraction and don't allow. And moreover, if they not allowed to do anything in their mouth by use a support behavioral. Okay, if you want to manage the behavioral patient, normally we have two part of manage. First, use medicine, and second is use non-pharmacological approach. First, we should use non-pharmacological approach such as change technique, change environment, change time, or change caregiver, everything. If not work, you can use a pharmacological approach. You can consult the physician to prescribe some medicine to keep calm of this patient, so they can allow to do anything in the mouth.
Okay, thank you for your answer. Or maybe have some questions? No. Yes.
ได้
in Thai, okay. เดี๋ยวรอไมโครโฟนสักครู่
โอเคแปรงสีฟันไฟฟ้าhow effective between electric brush toothbrush and normal toothbrush. May I answer in Thai? Okay.
Yes.
ไม่ได้มีความแตกต่างนะครับระหว่างประสิทธิภาพแต่ว่าขึ้นอยู่กับว่าลักษณะของผู้ป่วยนะครับที่จะใช้เนี่ยเป็นแบบไหนคืออย่างนี้นะครับเวลาที่เราดูแลผู้ป่วยผู้สูงอายุหรือว่าผู้ป่วยที่มีภาวะพึ่งพิงเนี่ยสิ่งสำคัญเลยเนี่ยเราต้องการที่จะให้เขาเนี่ยช่วยเหลือตัวเองได้มากที่สุดเพราะฉะนั้นเนี่ยบางทีการใช้แปรงสีฟันธรรมดาเนี่ยก็อาจจะไม่สามารถทำความสะอาดได้เนื่องจากว่าการขยับเคลื่อนไหวแขนต่างๆอาจจะทำได้ไม่ค่อยดีแปรงสีฟันไฟฟ้าก็เลยอาจจะตอบโจทย์สำหรับผู้ป่วยบางคนแต่ถ้าถามว่าระหว่างแปรงสีฟันไฟฟ้ากับแปรงสีฟันธรรมดาเนี่ยผลลัพธ์ในการทำความสะอาดเนี่ยไม่ได้แตกต่างกันถ้าเกิดสมมติว่าเราวางหัวแปรงและขนแปรงได้อย่างถูกตำแหน่งแล้วก็ถูกวิธีนะครับแต่ว่ามันอาจจะมีประโยชน์ในแง่ที่ว่าคนไข้บางคนที่เขาไม่สามารถขยับแขนขาได้มากแล้วต้องการให้แปรงสีฟันเนี่ยมันเคลื่อนได้เองหรือคนไข้บางคนที่แปรงฟันเนี่ยค่อนข้างแรงเราต้องการควบคุมแรงให้คงที่การใช้แปรงสีฟันไฟฟ้าก็อาจจะเหมาะสมกับคนไข้คนนั้นนะครับแต่ว่าค่าใช้จ่ายในเรื่องของ การซื้อแปรงสีฟันเนี่ยก็เป็นสิ่งหนึ่งที่เราต้องนำมาคิดเพราะว่าแปรงสีฟันธรรมดาเนี่ยราคาค่อนข้างถูกกว่าแปรงสีฟันไฟฟ้าเพราะฉะนั้นเนี่ยผลลัพธ์เนี่ยมันไม่ค่อยได้แตกต่างกันมากนะครับก็อาจจะต้องพิจารณาเป็นเคส by เคสไปครับผม
ค่ะจะขออนุญาตเสริมนิดนึงค่ะคือก็ด้วยความที่ตัวเองทำงานกับคนไข้เด็กนะคะก็มีผู้ปกครองสอบถามมาเหมือนกันว่าใช้แปรงสีฟันไฟฟ้าดีไหมจากที่เราไปศึกษามานะคะแล้วก็ดูจากงานวิจัยเนี่ยการใช้แปรงสีฟันไฟฟ้าค่ะจะได้ผลค่อนข้างดีในช่วงแรกแต่ว่าหลังจากนั้นเนี่ยก็จะไม่มีความแตกต่างกันนะคะในเรื่องของการทำความสะอาดระหว่างแปรงสีฟันไฟฟ้ากับแปรงสีฟันปกติอาจจะเป็นไปด้วยของความที่ว่ามีความเห่อพูดง่ายๆว่าเห่อในการใช้ในช่วงแรกนะคะแล้วก็อีกอันนึงคือเวลาใช้งานนะคะอย่างที่อาจารย์ณัฐพลแจ้งก็คือเราจะต้องมีการสอนว่าใช้ยังไงคือส่วนปกติเนี่ยเราอาจจะติดกับการถูไปด้วย
ใช่ใช่
แล้วก็จะมีปัญหาเรื่องของว่าฟันเนี่ยสึกนะคะอาจจะต้องเวลาใช้แปรงสีฟันไฟฟ้าอาจจะต้องศึกษาดีๆว่าเราจะต้องวางตำแหน่งยังไงแล้วก็ออกแรงประมาณไหน
ใช่ใช่ครับอันนี้คือสิ่งที่สำคัญถึงแม้เขาจะทำงานได้เองแต่ว่าเขาจะต้องวางให้ถูกต้องนะครับกับทำอย่างถูกวิธีด้วย
Any questions? Okay. We appreciate the value knowledge you have shared with us today, and I am certain that your research and expertise will inspire all of us today to approach elderly oral care with a renewed innovation. Okay. It can be observed that not only Singapore but also Thai has a program for oral health care and checkups for elderly, and also promote oral function that contribute to an improved quality of life of the elderly people. So, ladies and gentlemen, we have reached the end of these sessions. I would like to express our sincere gratitude to all our distinguished speakers, respected guests, and all participants. We hope that the knowledge shared today will inspire further research, new insights and ideas, and lead to the development for innovative solutions to enhance our work for improving elderly oral health. Please join me in expressing our appreciation with a big round of applause. Thank you once again
Thank you
for
very much.
attending, and we look forward to seeing you at the future events. Have a wonderful rest of day. Thank you very much.
Thank you very much, and please remain on the stage for the group photo session. Okay. Invite moderator. Yes. And this time, I would like to request all of you to scan our QR code for the satisfaction assessment. Yes, I would like to know your feedback to improve our event organizing. Thank you. And now we will have 5-minute break for refreshment. Please enjoy your time. Thank you. Okay. Welcome back to the next session. The next session is also interesting. We will discuss about the palliative care and end-of-life care center for the elderly.
Check.
In this occasion, I would like to invite Dr. เดือนเพ็ญ หอรัตนาเรือง our moderator. She is from Queen Sirikit National Institute of Child Health, Department of Medical Services, Ministry of Public Health of Thailand. Please, thank you.
Thank you for your introduction and good morning, ladies and gentlemen. Welcome to the fifth Thailand Elderly Health Service Forum. This is the room, international room. The topic is the Palliative and End-of-Life Care Center for the Elderly. So I am pleased to be here today and I am very honored to be on the stage with our distinguished speakers. So today we will have 3 speakers, 2 from Thailand, 1 from Singapore. And this topic will highlight the importance of palliative care and end-of-life care for elderly people. How will healthcare system should focus on quality of death and quality of life and also quality of death, and how we should do it in different dimensions from hospital to community. And we will have experience sharing from different contexts, both from Thailand and Singapore. So with no further ado, I would like to introduce our 3 distinguished speakers. The first speaker is Dr. Jintana Asanasen from Ramathibodi Hospital, Thailand. So she's actually has a background from geriatric medicine and also specialized in dementia and now working as a as a faculty member of as an attending physician at Ramathibodi Palliative Care Excellence Center, Faculty of Medicine, Ramathibodi Hospital, Mahidol University, Thailand. Please welcome Dr. Jintana Asanasen. And our second speaker is she flew from Singapore and she's a palliative care physician, Dr. Ong King Jane. She's now Associate Consultant, Palliative Care Medicine, Changi General Hospital, Singapore. Please give an applause to her. And the third speaker is from Thailand, Mr. Ekapop Sithi Wanchana. He has a background of community work and public health, and he's done a lot of work in compassionate community, and also if you know the peaceful death and Pai Khai Chivit, it's all from his work. Please welcome Mr. Ekapop Sithi Wanchana. So our first topic would be the principle of palliative care and end-of-life care in elderly people, and we will hear the experience from Ramathibodi Hospital, Thailand. So please welcome the first topic by Dr. Jintana Asanasen.
Okay. Thank you very much for your kind introduction. It is my honor to be here today to share the experiences with you all today in palliative care and end-of-life care for Thai elderly. I am a geriatrician who works in the teaching hospital, so my focus today will center around the hospitalized older patients at my center. One of the most significant challenges for aging society is the increasing demand of healthcare and elder care services. The goal of geriatric care is to facilitate the best possible quality of life for older patients. The 4 pillars of geriatric assessment are physical, cognitive and mental, functional, social and environmental factors. As you already know, older patients have multiple comorbidities that cause physical impairment, cognitive impairment, and functional impairment. The more dependent they become, the more social support they need. For the partially dependent or totally dependent older patients, they cannot survive if they lack of adequate social support. So the big one, the outer layer, is palliative care. Palliative care is an approach that improves the quality of life of patients and their family members who are facing problems associated with life-limiting illness with any prognosis. It prevents and relieves suffering through disease-specific therapy and also symptom management on pain or other related symptoms, whether physical, psychosocial, or spiritual. The middle layer, the second one, is end-of-life care. End-of-life care is an approach that improves the quality of life and of the patient and family member who are facing progressive, incurable conditions and are likely to die within weeks, months, or up to 12 months. So in this phase, the patient also receives ongoing appropriate disease-specific therapy or hospice enrollment if their life expectancy are less than 6 months. The last one, the inner layer, is terminal care. Usually refers to the last few hours of life or the last few days of life when a patient is irreversibly dying. The main goal in this phase is only comfort-focused care. So, in palliative care, there are 3 common illness trajectories at the end of life. The first one is cancer trajectory, the blue line. It is a rapidly progressing or short decline over months to years. However, currently, novel therapy about cancer treatment, including surgery, targeted therapy, immunotherapy, chemotherapy, or radiation therapy, enable some cancer patients to live longer. But eventually, the cancer patient with advanced state who respond poorly or resistant to cancer therapy eventually develop a rapid decline in functional status with a clear end-of-life phase of worsening symptoms in the last weeks or months of life. The second one is organ failure trajectory, the yellow line. It is an intermediate decline in function over years with acute episodes of life-threatening exacerbation and intensive care. After that, the patient bounced back. And this trajectory typically occurs in non-cancer, life-limiting illness with organ failure such as heart failure, end-stage renal disease, COPD, end-stage death often seems sudden and may occur at any time along the trajectory with symptoms of end-stage organ failure. The third one is dementia or frailty trajectory. The green line is the gradual decline of physical and cognitive impairment with a long and variable disease from 5 to 10 years. The last year of life will be characterized by a steady decline with overall function, such as total dependence or bedbound status, with recurrent infection and frequent or multiple hospitalizations. Palliative Performance Scale, or PPS, is a 100-point scale with 100% representing a patient's normal activity level and 0% indicating death. It is a valid tool and correlates well with actual survival and median survival time for cancer patients in outpatient setting or ambulatory settings. It is very useful to identify or tracking potential care needs for palliative care patients with disease progression. The lower PPS score, the poorer prognosis. Cancer patients with PPS score of 10% to 30% who are totally bedbound have fewer survival days than those with the score of 50% or more. The PPS better predicted 1 month survival than long-term survival, and mortality rates for most PPS score were higher for cancer patients than non-cancer patients. Clinical Frailty Scale, or CFS, is a 9-point scale that quantifies frailty based on overall baseline function in older patients. Higher score indicate increased frailty and also associated with multiple risks. The CFS predict 1 year all-cause mortality for older patients in the emergency department or the ICU. The CFS predicts survival time in a graded manner. In particular, older patients with CFS score of more of 5 or above, who are mild to moderately frail to severely frail, were associated with the worst outcomes. The Functional Assessment Staging, or FAST scale, is a widely recognized tool developed to track the progression of dementia. The older patients with severe dementia with FAST stage 7 or beyond are eligible for hospice enrollment. These patients are typically dependent on basic ADLs with urinary or fecal incontinence, inability to verbally communicate, recurrent infections such as aspiration pneumonia, UTI, or pressure ulcers. The screening tool for patients with palliative care needs has 2 steps. The first step is to answer the question, does the patient have a life-limiting illness, as the following: advanced dementia, septic shock, ESRD, end-stage organ failure, end-stage lung disease. If the patient has 1 or more check items, then continue to the step 2. The second step is to answer the question, does the patient have 2 or more unmet palliative care needs, as the following: 2 or more unexpected emergency department visits or hospitalization in the last 6 months, uncontrolled pain, dyspnea or delirium, uncertainty about goals of care, or life expectancy less than 12 months. If the patient has 2 or more check items, then palliative care referral or consultation is recommended. Advanced care planning, or ACP, is the vital step. It's a voluntary, ongoing process that involves in discussing and preparing for future decisions about the patient's medical care, if the patient becomes seriously ill or unable to communicate their wishes. In general, physicians inform the patient about their prognosis, exploring treatment options, and helping the patient to express their values and preferences based upon a risk-benefit analysis. Advanced directives, or AD, are the documents that the patient complete while still have decision-making capacity to ensure that their values and preferences are reflected when considering how treatment decisions should be made on their behalf in the event that they lose decision-making capacity. It is not uncommon that preferences of life-sustaining therapy, such as endotracheal intubation, CPR, inotrope, hemodialysis, might change over time. So, advanced directives should be periodically revisited. In particular, at times when there is a significant change of the patient's health or they are in their serious or critical illness. Appointing a trusted surrogate decision maker or SDM is the cornerstone of effective substitute decision making in the event of the patient is incapacitated. A surrogate decision maker should be identified for all patients, regardless of condition. ACP significantly improve multiple outcomes, including patients with serious illness. This includes higher satisfaction with the quality of care due to improved communication between patient, family, and surrogate decision maker and their doctors, resulting in a shared decision making that leading to reduced hospitalization at the end of life, fewer intensive and life-sustaining treatment at the end of life, reduce the cost of end-of-life care, and increased likelihood that a patient will die in their preferred place, whether home, nursing home, or hospital. A competent patient has the legal right to refuse medical treatment in terminal illness, in which a patient will choose higher quality of life over quantity of life. That's the most important, the best possible quality of life that they want to be. Based upon the patient's autonomy and their best interest, it is important that the physician should provide the right treatment for the right patient at the right time. So it is a patient-centered care. It's not a physician-centered care at all. That's right. So a holistic patient-centered approach aims to provide a goal-concordant care to ensure the patient's values and preferences and are reflected when considering how treatment decisions should be made on their behalf in the event that the patient loses their capacity. To allow natural death, AND, is a written record of a decision to not treat the patient with CPR if they are in the terminal illness. It is very important to clarify that do not resuscitate does not mean do not treat. Do not resuscitate does not mean do not treat. The physician and healthcare team will never abandon the patient who prefer to allow natural death. These patients still receive the standard treatment and symptom management to relieve their suffering at the end of life. let's talk more about my center. Since 2010, Faculty of Medicine Ramatipedi Hospital has been developing a palliative care services, including consultation at the emergency department, at the ER, at the resuscitation room, ICU, wards, oncology clinic, palliative care clinic, telemedicine, and home-based palliative care. Our palliative care team consists of palliative care physicians, palliative care nurses, pharmacists, social worker, and a music therapist. Our palliative care program meets the disease-specific certification standard in palliative care, or DSC in palliative care, which was created by the Healthcare Accreditation Institute, or HAI. Discussion about the end-of-life care often involve a multidisciplinary approach. We involve primary care physician, palliative care specialist, intensivist or oncologist, or pain specialist. The discussion usually address concerns about the patient and family, such as understanding prognosis, relieving physical or spiritual or mental sufferings, or achieving important end-of-life goals. Good communication can facilitate a shared decision-making. It is a joint process in which a healthcare personnel works together with the patient and family member and surrogate decision maker to develop a treatment plan that is concordant with the patient's wishes and values. Providing a good death in the hospital, at the medical ward, in the last day of the patient's life. Mostly, the dying Buddhist patients usually wish to be conscious and would appreciate peace and quiet room to listen to Dhamma, and they may do a ceremony of offering dedicated to Buddhist monk or Sankhathan. Music therapy can help to lessen feelings of isolation or loneliness by providing opportunity for social interaction and the sharing of personal experiences with others. For terminally ill patients, music therapy can serve as a trigger to establish both verbal and nonverbal communication. So, the skilled use of music can facilitate emotional self-expression and provide supportive and non-threatening environment. That thank you messages. Thank you very much. The music therapy really made my day. It is one of our best time. That's my terminally ill patient. Faculty of Medicine Ramatipedi Hospital has a 6-bedded Ramatipedi Palliative Care Unit, or RPU. The RPU provides inpatient care for patients in the last hours of life or last days of life, and also for patients with uncontrolled symptoms at the end of life. Let's talk about a home-based palliative care. To facilitate a good death at home, this is what we are doing by video call them at home. Our team offers a 24 on-call monitoring by palliative care nurses and physicians through the Line application and telephone, building a good rapport and trust between the patient, caregivers, and family member is a vital part of our service. The 24/7 availability of our palliative care nurses, online application and telephone ensure extra care, ensure compassionate support, and comfort in all aspects of care to meet the physical, social, psychological, and spiritual needs of the dying patients and their caregivers and their family members. This reduces the patient's and family stress, anxiety, and depression. In most cases, with active symptoms, the symptom management in actively dying patient is achieved by administering medication through continuous subcutaneous infusion or CSCI at home. Our services include medical equipment rental and caregiver education. Our team offers the portable oxygen generator rental and syringe infusion pump rental for days to weeks to actively dying patients at home. The palliative care nurses also teach and demonstrate caregiver and family member how to use the oxygen generator and syringe infusion pump step by step. These are the example of monitoring active symptom of dying patient at home by our palliative care nurses through LINE application, LINE messages, and LINE call. They can call us at any time for actively dying patient. These are also the example of monitoring through LINE application, video clips, and video call. They can send us. What is this that mean? What is this mean? So we can help. This service facilitates a good home death and also provides spiritual, psychological, and emotional support. At the last hours of life or last days of life, it is very beneficial for patient, caregiver, and family members. So to truly empower caregivers and enable them to deliver end-of-life care for their loved ones and better preparation them on what to expect about the dying process. Let's talk about goal concordant care or person-centered care, patient-centered care, not physician-centered care. Fulfilling the terminally ill patient's last wishes is the ultimate goal of life of that patient and ultimate goal of our team. This is a hardworking father. His last wish was to attend his son's and daughter's graduation ceremony. Our team convinced the family to have a mock graduation day and take the photo at the medical ward. So we did not know that he could make it. Surprisingly, he made it. He was able to attend his son's graduation ceremony at the university, and then he died peacefully a few weeks later. This old man was very worried. He's not worried about his symptom, but he was worried that his youngest daughter, he is a terminally ill cancer patient, and his last wish was to attend his youngest daughter's wedding. But he is critically ill. So our team simply organized a short but sweet wedding ceremony at the hospital, at the medical ward. This is the bride and the groom and the father. And then he died peacefully a week later. This musician, he has a gastric cancer with multiple metastases. The wish of this musician was just to play his favorite woodwind instrument. We call it in Thai can. For the last time, after home arrival, his relative and family member arranged a traditional spirits blessing ceremony for the sick, or what we call พิธีสู่ขวัญ or พิธีเอาขวัญ a common practice in northeastern Thailand. Eventually, he died peacefully at his very own bed. This father, who loved classical music very much, asked his son to have a karaoke birthday party at the last week of his life. This great grandma asked her niece to play her favorite Thai drama, Love Destiny or บุพเพสันนิวาส at the last day of her life. Who would you choose to spend the last day of your life with? I don't think you want to spend the last day of the life with medical team, but your beloved one, would it be holding hand with your better half or your wife for 60 years, or just holding hand with your favorite great granddaughter, or just cuddling with your beloved cat till the last breath of your life? From a good death to better bereavement, the impact of good end-of-life experience on bereavement adjustment of caregiver and family member. These meaningful appreciation and thank you messages to our team are the concrete proof of better bereavement as follows. Dying isn't scary anymore if we understand it. Palliative care team is like a compass to keep us from getting lost and make us understand the truth of life. A considerate stranger who is supportive and ready to help at any time. You are always by my side throughout the journey and take care of both body and mind of the patient and family member when we need you the most. To kill sometimes, to relieve often, to comfort always is a good reminder that the role of PC team as a comforter must provide basis of our care, regardless of whether we can relieve suffering or cure disease or not. And this is what the patient wants the most, to comfort always. So, this is my team, Ramatipudi Palliative Care Excellence Center. Thank you very much for your attention.
Thank you, Dr. Chintana, for your inspiring and excellent talk. Dr. Chintana has explained to us the phase of healthcare for elderly. So the elderly people will pass the healthy aging, active aging phase, health decline, dependent, and then going into palliative phase, end of life, and then terminal days. It's just the nature of life. And then thank you for showing us the concept of trajectory of the disease in palliative care and the detail of the PC in dementia patient. I think because my father also has dementia, so I know the pain point of taking care of dementia elderly people. And you also made many of the keywords, like no one should have, everyone should have the right to die in their preferred place and also have good death. It should be the right of the people. And patients and family-centered care instead of physician-centered care, this is the good one. And of course, the shared decision-making is the keyword. One will not be abandoned regardless of their state of health. And thank you for showing us an excellent example of the service in Ramathibodi Hospital. And then we'll move along to our neighbor ASEAN country. We have known that Singapore has advanced into the aging society before us, but now I think we may, get beyond you regarding the percentages of the elderly people. So the next speaker, Dr. Jane, will share with us the experience from Singapore, please.
Thank you. Sawadika. I'm Dr. Jane. So I'm actually from Changi General Hospital in Singapore, and I would like to share with you today about our palliative care service. Today I'll be talking about how the elderly are cared for at the end of life in Singapore. So my content will include an introduction and about what palliative care is about in the elderly, how we assess their symptoms at the end of life, the palliative care management, the goals of care in the elderly, and their preferred place of care and death, as well as Singapore's strategy for palliative care. So first of all, an introduction. So the palliative care service is actually under the Department of Geriatric Care, and within the department itself, there are actually several services, and palliative care service is one of them. So this is my team. It's not a complete team because it's very hard to get everybody together. Someone is always somewhere managing a patient or doing something else. But this is as many people as we can get. We started in 2012, like I said, under the Department of Geriatric Medicine. We still are still under the same department. We have a multidisciplinary team. As of today, we have 3 consultants. I'm one of them. There are 6 resident physicians. And we are divided into 3 different teams. And under each team, there are also 8 nurses. And there's 1 poor social worker who has to take care of all our patients within all 3 teams. Okay, what we do. We actually see patients within the acute hospital. We have no beds of our own, but patients from other specialties make a referral to us, and then we go and see them. So our patients are all over the hospital. And we have 2 inpatient wards, so we are always running back and forth. We chalk up a lot of steps every day, running back and forth, seeing all the patients. We have around 100 referrals every month, and it's actually increasing over the years. Our cases are cancer cases and non-cancer cases. And they are actually a mixture. Some are at the end of life, some are not, but they have a lot of symptoms. And we have increasing number of cases for what we call compassionate discharge. I will talk about compassionate discharge later on. But it's basically about a discharge from the hospital to go back home or to nursing home to die there. We also run a half-day outpatient clinic once a week. We also help out with the nursing homes in the eastern part of Singapore because Changi General Hospital is located in the eastern part. So we help our nurses go to see the patients in the nursing homes, and our consultants actually provide a consultation service. So if the nurses need help, they call us. Okay, we also work very closely with our neighbor, St. Andrew's Community Hospital. Our consultants actually help out in their inpatient hospice wards, the home hospice, as well as in the nursing homes that St. Andrew's Hospital has. So now we go on to the next section on palliative care in the elderly. This is the definition by WHO of palliative care. So it is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness. And this is by prevention of relief and suffering, by early identification as well as assessment and treatment of pain and other problems that are physical, psychosocial, and spiritual. I think this was already covered in the previous talk, so I will not elaborate too much. And in Singapore, our population is actually aging quite rapidly. In last year, 2024, only 19.9% of our population was 65 and above. Yeah, only. Yeah? So by 2026, we are going to become more than 20% who are 65 years and older. So we will be super aged. And by 2030, 25% of our population will be 65 years old and above. Yeah, so it's very rapidly aging. And our death statistics so far is that a lot of our population die from cancer, followed by pneumonia, which is a lung infection, as well as heart disease and cerebrovascular diseases like stroke, and also hypertensive diseases, which involves either a heart failing or there's also from stroke. So these are our top 3 killers. And the types of diseases that are seen by our team in Singapore will include around 60% of cancer patients as well as 40% of non-cancer patients, and they usually involve an organ that has failed. So of the cancer patients, some of them are terminal. Some are actually many of them the cancer has spread everywhere, so it's metastatic. And some of the cancers are actually early, but they are very, very symptomatic. So we get a referral to help with the symptoms. The non-cancer patients include the patients with heart disease, like ischemic heart disease, heart failure, aortic stenosis, because these patients usually are either quite breathless or are still having chest pain. For the patients with lung diseases, they are like pneumonia, our chronic obstructive lung diseases, usually from smoking, interstitial lung diseases, and again, these patients are usually very, very breathless. We have patients with kidney failure, whether or not they're on dialysis or not. A lot of them also have fluid overload and also breathlessness. And sometimes they have a lot of aches and pains. Liver cirrhosis patients, usually they also have a lot of issues because it causes a lot of other organs to fail also. And then we have patients with neurological diseases, such as patients with very massive stroke or patients with dementia, and or Parkinson's or motor neuron disease. So these are the variety of patients we see. And how we assess symptoms, I will quickly go through it because I think it's been talked about before. So our patients usually have pain or breathlessness, nausea, vomiting. Some of them are delirious, especially the hyperactive type who are usually agitated or very restless. Some of them are actually drowsy. They have throat secretions, especially at the end of life. They have loss of appetite, loss of weight, urination problems, bowel problems. Some of them are depressed, and some of them, actually many of them, have spiritual struggles. So just to go briefly into the most common symptoms that we see, which is pain. So for the patients who are able to speak to us, who can communicate with us, or who have a very good caregiver who can tell us what's happening, we usually get a verbal history from them. So they tell us what's happening, how bad the pain is, where is the pain. But there are some patients who cannot tell us anything. They are either too drowsy or they are too confused. So that's when we use a few of the tools to help us. So for pain, we have this tool called Pain-Aid and Flex Score. I'll show you later. And for breathlessness, we have this score called RDOS score. Again, I'll show you later. So this is Pain-Aid. Even though it was designed for use in dementia patients, but many times we also use in our non-communicative palliative care patients. So we look at their breathing. We look at whether they have negative vocalization, meaning they keep moaning and groaning or crying out. Facial expression, whether they are frowning. Body language, whether they are thrashing around or they keep rubbing over the painful place. And consolability, some of them are just mourning away and you just cannot stop it, or they are crying away and you cannot stop it. So these are the ways that we assess whether or not they are in pain. The other way is by what we call the Flex Score. So it's also very similar. It was actually also designed for a different group of patients. It's actually for the pediatric patients. But studies have shown that it can be used for our palliative group of patients and even the elderly group of patients. So what we look at is the face to see what's their expression like. We look at their legs. Are they very restless? Are they kicking away? Did they curl up their legs? We look at what they're doing, the activity. Do they look very tense? Are they relaxed? We also listen to whether they are crying or moaning or groaning. And we also see whether they are consolable. So if we go there and we soothe the patient, if the patient can be calmed down easily, we know that the pain is not so severe. The RDOS that I was talking about is about the respiratory distress observation scale. So this is again for patients who are in a coma state or too drowsy to tell you whether they are breathless or not. So we look at a few things. We look at their heart rate, their respiratory rate, how fast they're breathing, whether they're restless, paradoxical breathing, such that the abdomen is actually moving in when they're breathing in, okay? And accessory muscle use, basically it's the muscles over the neck, whether it's moving a lot while they are breathing, whether they are grunting at the end of their breathing, whether their nostrils are actually flaring out because they're breathing very hard and fast, and whether they have this look of fear, because when you can't breathe, you are actually very frightened. So in the international studies, if you meet a score of 3 and above, it means that you are in respiratory distress. But in Singapore, we actually did our own study, and we actually found that if you have a score of 4 and more, that's when the patients are really in respiratory distress. So over in Singapore, locally in Singapore, we actually use 4 as the cutoff point instead of 3 as seen in the studies in the Western countries. Symptom assessment, using functional assessment, I think I won't go into that. I think the palliative assessment was used just now, the PPS. Some other scores that we use is the Karnofsky status as well as the ECOG status. ECOG status is usually used in cancer patients because the medical oncologists use that. So to speak the same language as the cancer doctors, we also use ECOG. And this is all related to the prognosis, which means how long more the patient has. It guides us in our treatment because if the patient has a longer life expectancy, we can offer more treatment or treatment that can take a longer time to work. And also tells us about the level of care that's needed. The other symptom assessment that we look at is actually before we go into the psychosocial, we look at the Asian family dynamics. As you know, in our Asia culture, we are very related to one another. We have our own family, we have our grandparents' siblings, our grandparents' cousins, our cousins' cousins, and so on and so forth. Everyone is related. Yeah, so it's important to get a family tree. It's important to know who lives with who. It doesn't mean that the father lives with the child. Sometimes it could be a cousin, it could be a nephew, it could be a granddaughter or grandson. Yeah, so we need to find out. We need to know who the caregivers are. Just because you are the son doesn't mean you are the one caring. It could be the son's wife. It could be the son's daughter who's caring. We need to know about any relationship issues. As you know, in a big family, even in a small family, there are a lot of undercurrents. I may be fighting with my son, but I love my daughter a lot. You don't know, so we need to ask. And we need to know who's the main spokesperson, who is the one speaking on behalf of the patient, which in our Asian family may be different from the main decision maker. So the person who makes the decision, from my experience, is the person who pays the money, who pays the bill. That one makes the decision, even though the spokesperson may represent the patient. Yeah, so all that we have to find out. Yeah, so after finding out all that, then we have to dwell into the psychological issues, the psychosocial issues. In our Asian culture, cost and money is a big issue. We are always worried about that. We are worried about burdening our children with all other expensive medical treatment. We are worried about our own health. We're worried about being a burden in other ways that we have to, we hinder our children's career because they have to take leave to take care of us. And then the caregiver who's taking care of the patient also gets distressed because sometimes they are not supported. There's also a lot of spiritual issues, depending on the religious belief of the patient, and the patient is also grieving about the loss of health, loss of life, loss of relationships, especially in younger patients with very young children, loss of role if this patient was a breadwinner, earning all the money for the family, and now he cannot anymore. Yeah, and then he's grieving about the loss of money, and there's also anger sometimes. That is so unfair. Sometimes my patients tell me, I eat carefully, I exercise, why do I get cancer? Why is it the smoker doesn't get the cancer, I'm getting the cancer? And sometimes they get angry with their God, whoever their God may be. God is blind, God is unfair, so they are dealing with all these issues. Then they ask themselves about what's the purpose of their life, what's the meaning of their life? Is there any more meaning now that they are so useless? Yeah, so these are all the issues that we also go into with our patients at the end of life, especially the elderly ones. Yeah, and so now we go into the palliative care management. So our team is a multidisciplinary team. We have doctors, nurses, pharmacists. Our social workers are very important because they help us with a lot of the psychosocial issues. We have the psychiatric occupational therapists. We have a physical therapists, the physios, as well as the occupational therapists, the speech and language therapists, the dietitians, and also the music and the art therapists. So I won't go too much into the medications, but these are examples of some of the common medications we use in Singapore. We use morphine quite a lot, but we're very careful when patients have liver and kidney failure because the morphine stays in the body for a much longer time. We use fentanyl. It's safer in kidney failure because the metabolite is inert, which means it doesn't affect the body in any way. But we do reduce the dose and the frequency in patients with liver failure. We use oxycodone. It's quite expensive, but it's useful for some patients. And again, in liver and kidney failure, we actually reduce the dose and the frequency. We use tramadol, but we need to take care that in the elderly, the maximum dose is only 300 milligrams. And for the elderly with kidney failure, the maximum dose is 200 milligrams a day. We use paracetamol sometimes, but we need to know that, again, in the elderly and the liver failure, it needs to be reduced in dose. Sometimes we use NRX, but we're very, very careful in the elderly because it can cause them to fall down if they're still walking around. We use gabapentin and pregabalin. Again, there's going to be reduced dose if their kidneys are not good. We use a bit of benzodiazepine, again, taking care if the kidney is no good. And we use metoclopramide and domperidone in kidney failure, but we have to take care if they've got heart arrhythmias. And antipsychotics, also same thing, caution in the elderly, and we take care in heart with arrhythmias. And we generally avoid it in Parkinson's disease. So for symptom management in elderly at the end of their lives, some of the symptoms that we encounter are restlessness or agitation. So they are very, very confused, they're delirious, they move about. Sometimes they have swallowing issues, so their saliva tend to pool at the back of their throat. So you end up hearing a lot of noise when they're breathing. So these are throat secretions. It's also otherwise known as the death rattle. They get pain, they get breathless, some of them get vomiting, some of them have seizures. So at the end of life, we actually use the non-oral routes because we know they cannot swallow properly. For the bladder care, we need to also take care about changing their diapers, and if they can't pee on their own, we have to put in an indwelling catheter so that the urine doesn't get stuck in the bladder. And for bowel care, many of these patients are constipated. We have to take care to prevent constipation, but yet we cannot overly soften their stools because if their stools are too liquid, what happens is that sometimes it can cause a lot of excoriation or a lot of dermatitis around their anus region, and sometimes it can actually cause sores to develop. Then there's also care of the wounds as well as pressure injuries. So we need to do wound dressing, we need to do regular turning. Usually it's around every 2 hours. And mouth care, it's very uncomfortable for them to have a very dry mouth. Some of the medications that we use can also cause their mouth to dry up. So we try to keep their lips and their mouth, the oral cavity, moist. And then some patients have stoma, they have other tubes and drains, so we have to take care of those also. So this is actually the general management of these patients. So now we come to the goals of care in the elderly. It's very important to talk about the goals of care because knowing what the elderly want will help guide us in our treatment. So there are three ways of goals of care, three types of goals of care. One is curative, one is palliative, and one is comfort care. So for the curative patients, usually after discharge from the hospital, they either go home or they go to a nursing home if the family cannot take care of them. For the patients who are on a palliative type of treatment, usually the treatment we give is limited, and when they get discharged from the hospital, they either go home or to the nursing home. And for patients who are on comfort care, we just aim totally at symptom control. And usually these patients also have got a short life left. So they either go home if they have the family who can take care of them, or they go to the nursing home or the inpatient hospice, which I'll talk about later. So in Singapore, we also have advanced care planning. And our aims of advanced care planning is to find out what the patient's values, goals, and preferences are, meaning what they actually want. We use that to plan for future medical treatment and care. We also usually try to get the family or at least the substitute decision maker to be in the same conversation and so that they know about what the patient wants. And if it's possible, the healthcare providers to be there too. If not, then we'll inform them after that. And then we record their decisions and we record the conversation. And then this document can be actually reviewed time and time again. Usually we encourage this document to be reviewed every time the patient gets admitted to an institution or when there's a change in medical condition. So in Asian societies, many of the societies have Confucius values. In Thailand, it's probably a lot of Buddhist values. And so many of these patients are usually not willing to discuss about end-of-life issues. Maybe they are superstitious, maybe they're not willing to think about it. And the patients many times, especially the elderly, do not want to make healthcare decisions on their own health. Many of them say, let my son decide. If they have no sons, they say, let my daughter decide. Usually they don't want to decide on their own. And in our Asian culture, many times the family is involved. The family wants to know first. The family wants to decide. And usually, as a result, the doctors and the nurses, we seldom involve patients in advanced care planning. We talk to the families first. But right now, I'm not sure whether it's right or wrong because if the patients want to know, sometimes they do have a right to know. But many times we have to do it very carefully because the families are very protective. Yeah, so the treatment preferences are usually guided by the families and sometimes by the doctors themselves, and it's based on relationships and responsibilities towards one another. So, for the Asian culture in Singapore and probably in Thailand also, we have to take into account all this. Instead of approaching the patient directly, usually the patient care involves a lot of people in the family. So now we come to the preferred place of care and death, because that will be also involving the family as well as the patient sometimes in discussion. Okay, so preferred place of care and planning is actually part of the advanced care planning discussion. The preferred place of care can include either the home, going back to your own home, going to a nursing home, going to the inpatient hospice, and there are some patients who prefer to pass on to be cared for in the hospital. In 2014, the Lian Foundation in Singapore actually did a survey, and they found that 77% of the patients prefer to die at home. In 2020, it was found that 61% died in the Singapore hospitals, so it's not at home. And so what happened is that our health ministry wants to reduce the hospital deaths from 61% to 51% by 2027. This is what the Minister of Health hopes for. This is what we are trying to do. So what the Minister of Health wants us to do is to teach the public about palliative care, make hospital discharges much smoother, increase our palliative care service, especially in the community, give better support for the caregivers at home because many times they feel very alone. And so what happens is that Singapore Hospice Council actually created this website with a lot of resources online for caregivers, for health professionals, as well as for the general public. So all this information, they just go into the website and then they just click on it. This is actually taken from the Singapore Hospice Council website. So now we talk about compassionate discharge, which was something that the Minister of Health wanted us to do more so that the patients can go home and they are dying when they've got a few hours to less than a week left of life, they can rush home and so they can therefore pass away and die at home. So the other names that we have for compassionate discharge is called terminal discharge. I think in the Western world it's called rapid discharge, but we've decided to call it compassionate discharge. So it's an urgent discharge for patients who are critically ill, where their time left is very, very short, but they want to die at home, or some of them want to go back to their nursing home to die. So we expect the death to happen within hours to 1 week. So because this is such an urgent discharge and there's such a short time given to us, many healthcare teams have to work together to prepare all these medically unstable patients to go home. So many of these patients actually have very low blood pressure. So it's very critical because any time the blood pressure can just dive. And so what happens is that we have created this, basically the palliative care fraternity in Singapore has created information in each individual hospital. So Changi Hospital has also we have created a lot of information that's available in our intranet so that other medical teams can get information from there. Caregivers can get information from there on what to do. Hospice websites also have information for both the medical teams as well as the caregivers. So this is an example of the information that we have created. This was actually published by my nurse, actually my whole team of palliative nurses in the BMJ. And we created all these resources that's actually easily available to the caregivers. And there are a lot of photos in there to teach the caregivers how to administer the medications. Because remember, a lot of these patients cannot take oral medications anymore. So a lot of the medications need to be via subcutaneous injection or via the rectal route. So all these pictures were actually created for them. And a lot of the medications that we stringe out before they go home, we actually tag them with colored labels so that even if you cannot read, you can go by the color, and then based on the symptoms, you can give the injections. And what happens is that we also put an injectable under their skin already, so that when the caregivers inject the medications, they don't use needles at all because there's actually a cannula inserted and they can directly just inject in. So then it takes away the fear of needles because many caregivers are very scared to inject any needles into the body of their loved ones. So now we take away the needle part. We actually let them just directly inject the syringe of medication in. So these are the things that we do to help the caregivers take care of the families at home and make it easier for them. So some of the teams that we have in the community to support the patients if they go home or go back to the nursing home, one of them is the home hospice team. So the home hospice care team actually takes in patients, cancer as well as non-cancer that's expected to get worse. And usually the criteria is if they have less than 1 year of life. So it's a nurse-led service, so which means majority of the patients are seen by the nurses. But when the nurses need help, they bring in their doctors. Or there are also other allied health workers who are helping. If the patient needs some medical social help or physical therapists or spiritual care counselors, the nurses will call them in. But most of them, the nurses go in first. They accept all patients for compassionate discharge. There's a 24-hour support service. It's either by phone call. If they can advise the caregivers over the phone, they will do that. If not, they can actually bring their whole bag over to visit the patients even in the middle of the night. There's daycare option for some patients. Some of the home hospices offer that. So those are the patients who are generally more well, who are able to sit up for many hours, and then they go to the home hospice daycare center, and they can do activities there. Then for families who need extra help, The home hospice can refer to a home-based respite care. So these are actually nurses who are trained to take care of the patients at home. They can do nursing care. So this can help support the very tired caregiver. And the home hospice service right now is actually free or very, very low service, very, very low fees. And that can be taken from the National Savings Program. So in other words, there's actually very little cash use. Then the reason why it's free is because we want the families to dare to seek help. Because if it involves money, many people don't seek help. Yeah, and actually many of these home hospice organizations are charitable organizations. So they raise money through donations. So because the government financing is not enough, so many times they have yearly fundraisers to raise money. So one example is the Violet program that Changi Hospital works very closely with. It's also a home hospice program. And the photos are some examples of them visiting the patients. One is visiting the patient at home. The other one is a nurse visiting the patient in a nursing home. So it was started recently in 2020. And it accepts a lot of patients from Changi Hospital. So they care for, their main area is to care for the non-cancer patients with end organ failure or the dementia patients. Why do they do that? Because they see a need, because there are a lot more home hospices that take care of cancer patients. And so they see the need in the patients with organ failure. So that's why they decide to focus on that. Again, they take patients who have less than 1 year of life. Their aim is to keep the patient comfortable at home or in the nursing home and to prevent unnecessary hospital admissions. They accept all patients for compassionate discharge. So which means if it's an urgent discharge home to die, whether you're having cancer or non-cancer, they will take. And again, it's a nurse-led service. Same thing, is supported by the palliative doctors. I'm one of them. And there are also social workers, physical therapists, and spiritual care counselors to support. And they also give 24-hour service. Again, first of all, the patients or the family will call for help. If the nurse or the doctor on the other end of the line finds that they need to visit the patient, they will go down to their homes to visit. We have an advantage because Singapore is very small. Yeah. So in 2022, this group actually received the Singapore Health Quality Service Award for the Best Team Award. There are other types of home-based services in Singapore also. So there's actually Meals on Wheels. These are for patients who cannot cook for themselves, who cannot go to buy food for themselves. We deliver the meals. There's also medical escort and transport service, which means that if the patients need to go back to the hospital to see the doctor, they actually do provide the escort, and as well as the transport to take the patient to the hospital and take the patient back home. There's home medical service for patients who are not at the end of life yet. There's home nursing service, especially for patients with wounds or with drains and stomas that need help. The nurses go in. There's home therapy service for patients who need physical therapy at home. There's home personal care service. So this service is actually, they go in for a few hours to help bathe the patient, because sometimes the patient, if you have one caregiver, you can't move the patient to the shower to bathe. So you have the home personal care service. They come in, they help to sponge the patient or shower the patient. Then, of course, hospice home care, which is what I talked about already. And home-based respite care, which I told you, is actually an extra help coming in to help the caregiver take care of the take care of the patient. Then the other program that we have is called the Eager Care Program. It's basically the target is actually to go to the nursing homes to take care of patients. So Eager Care stands for Enhancing Advanced Care Planning, Geriatric Care, and End-of-Life Care in the Eastern Region. So it was started in 2015 by the Geriatric Department in Changi Hospital. It's basically catering to nursing homes that are near Changi Hospital. It's also a free service. It's provided by the Ministry of Health. And they work very closely with St. Andrew's Community Hospital as well as the general practitioners to help take care of these patients in the nursing home. So initially, their aim was to train and to support the nursing home in doing advanced care planning, geriatric care, and end-of-life care. But then later on, they realized they have to do hands-on and demonstrate for these nursing home nurses. So the nurse goes in there and supports them, and they also help take care of those patients. And again, if they need help, they call upon the palliative care doctors or the geriatric doctors. Sometimes they bring in the social workers, the physical therapists, and the spiritual care counselors. And again, it's a 24-hour support service. So sometimes the nursing home nurses can call if they need help because the patient has developed some symptoms. And many times the on-call doctors go there in the middle of the night to set up an infusion or to help take care of the symptoms. Again, their aim is to reduce unnecessary hospital admissions. So the Eager Care program today has involved 16 nursing homes, sorry. So there are 16 of them involved. Again, the goal, same thing, reduce admissions and to improve the nursing home residents' quality of life by allowing them to be comfortably cared for in the nursing home at the end of life instead of sending them back to the hospital where they get poked unnecessarily. And between 2020 to 2022, they have trained more than 500 nursing home staff in doing advanced care planning in geriatric care as well as in end-of-life care. And there are more than 500 nursing home patients involved in the program. And 99% of these nursing home residents' treatment preferences were honored. And 91% died in their preferred place of death, which is in the nursing home. So because of this program, a lot of them actually can continue to be nursed in the nursing home all the way till the end of their lives. Okay. So so our inpatient, then we have another thing which is the inpatient hospice palliative care service. Again, they take care of patients at the end of their lives, and this is for patients with less than 3 months of life left. Again, we take care of their symptoms, the end-of-life care, they do psychosocial and spiritual care. And the whole team is actually, again, a multidisciplinary team. And there are many standalone hospices in Singapore, as well as in many community hospitals. And again, the fees are very low. The government pays most of it. And it's free for the poor patients. So these are the number of inpatient hospices that we have. Now, this is an example of the inpatient hospice ward in the St. Andrew's Nursing Home, which is, again, like I said, next to our hospital. This is how it looks like in a single room, and this is how the ward looks like from the entrance. So, like I said, it's located in St. Andrew's Community Hospital. We have 24 beds, and works very closely with Changi Hospital, accepts many patients from Changi Hospital, as well as from the Violet Home Program. They also take patients from other hospitals and home hospices, especially if these patients live in the East. And again, they provide end-of-life care. And actually, I go over to cover that hospice ward also. So the National Strategy for Palliative Care. So this is instituted by the government. So what triggered it was that in 2010, Singapore was ranked 18th in the Quality of Death Index. So our government was not happy to be 18th. So that triggered our government to set up a task force to form the National Strategy for Palliative Care. And then that very year, we came up with guidelines for palliative care management. There are 4 domains and 13 guidelines. I will not go into the details. The aim is to improve palliative care in Singapore and to attain a high quality palliative care. And then in 2015, 5 years later, we became 2nd in Asia and 12th globally. So our government was quite happy after that. Yeah, so this is just an example of how the national guidelines for palliative care looks like. The contents page is actually in the middle section, and there's a workbook for the individual hospices to do self-assessment to see whether they meet the standard. So as a result of that, we actually got some data from after the program was started, and we have seen that basically fewer patients who are with the hospice actually died in hospital, and a lot more died at home or in the inpatient hospice. And we also looked at the type of care that the cancer patients received. So the median time from the first patient assessment to death was around 22 days. Yeah, and this is actually the national strategy in summary, in a pictorial summary. Okay, that's the end of my talk. Thank you.
Thank you so much, Dr. Jen, for your excellent talk. Very interesting. Because of the timing, actually, I have a lot of questions, but we will keep it if we have time. Of course, that Dr. Jen had talked about the importance of symptom management and the holistic care, and it's all related. Somebody just think that physical is physical and then psychosocial, spiritual, but it's all related. And thank you for introduce us to the word compassionate discharge. It's a very interesting word. We are planning to have similar thing in Thailand. It's called home ward, like, you know, but we may discuss that later. But all of these, you can see that it's all connected to community and home, right? So I myself believe that community empowerment is very important for the movement of taking good care of elderly people at their end stage of life. So we are privileged to have our expertise with us. No? Mr. Ekapop will talk about the compassionate community and its importance for supporting care for elderly people in community. So please.
Thank you. And thank you to inviting us and our network to come to this conference. And we have a Peaceful Death booth outside that we have tools and activities to promote compassionate communities and palliative care at the social sectors. I'm Ekapop, that I am a knowledge manager to invite all peoples, all sectors to come to care the end of life. Like this illustration, there are a lot of peoples in this caring, families, neighborhood, doctors, and others. Also dog, and that will include into the care environment. So palliative care for our views is more broadly, widely, and early to promote. So the compassionate communities is a term to bring everyone together to care the end of life, terminal care, and before that, elderly care also, and also prevention and promotion in palliative care. In the formal sectors of communities, like a local service, like a government service, and also informal network, like a neighborhood, friend from home, yes, fortune teller, everyone's invited. We encourage facility support and celebrate at the difficult times in the caring. And in the Buddhist views, suffering is an opportunity to grow, to foster compassionate, more bring wisdom to our life, to our to families. Compassionate communities is one of the components to provide palliative care for all population, allies with the palliative care professionals, allied with the healthcare workers, allied with the hospital, and also the policy levels, policy governors. So we acknowledge that we are in the important part. So this is a definition of the communities. Everyone's is communities. We grow from the public awareness from the Buddhist network that bring the Buddhist teaching to the present life, and grow with the public awareness to palliative care and compassionate communities. Last years, we also do the compassionate city program that work more on the policy levels. So we are allied with the all part of palliative care movement. And the last years, we include in this research from the compassionate community researcher around the world by the Switzerland, Argentina, Colombia researcher that come together and research what's the benefits if one country or one communities do the compassionate community programs. So there are 3 major benefits that we found, and in Thailand we have all of it. You can download this guide to evaluate your communities, if your communities have this initiative, or to guide if you don't know how to start, you can download this to start the compassionate communities. So there are 14 countries that involved in this research, and Thailand are one of these countries. The research collect data from all these countries and collect what if those compassionate communities do in the activities, and also we collect benefit. What is better? What is happen when we have compassionate communities in our countries? So there are 3 component benefit. If in the compassionate communities, we will give the awareness and information on palliative care. We can align organization and access to palliative care in the healthcare service, and also we do the education and support in the communities. So we have example from some communities that are in our network. This is awareness and information benefit that goes around with the public awareness on the elderly, illness, death, dying, bereavement. They will come to help people familiar more with these issues. They will change attitude toward death and palliative, and also we align with the forgotten population that also face the difficulties on end-of-life care. Like this, we can empower citizens, including understand the forgotten population. This is a prisoner that also have elderly in prison too. They also face the difficult times in the prison, but also there are caregiving in the prison too. So this is an initiative from compassionate communities, allied with the province Kalasin and Khon Kaen, that we can training the volunteer prison to caregiving to the elderly care in the prison. And also these skills can be trained to provide the skill to the prison. After they have privilege, they can go to be a carer for their communities. If we do the compassionate community program, we will have the public awareness on palliative care, death and dying in our community. Like this is an art exhibition to provide experience when you face 30 seconds before death. So they bring the attention, interesting for the medias and communities, and they will talk about what we have faced in the time of death, and also palliative care will bring into the conversation too. Like before I die walls that bring a conversation around death, dying, and bereaving. When you do compassionate communities in your areas, they will facilitate and creation coordination around public, around government, and communities to support caregiving, patient, illness peoples, also volunteers. Just so organization in community will be more stronger, more collaborate, and share network, share resource, share knowledge, and practice together in the communities. Like this one, we have the home care in the public nursing home care, that they are also have elderly care in their home care, but the lack of knowledge how to manage, how to conduct advanced care plan. So the Peaceful Death give a training and tools to elderly can do the advanced care plan with the facilitator with their carers. and it's implanted in the process of the inclusion of elderly care. So now elderly, every elderly have to do advanced care plan before living in the nursing home. So it's a setting organized in the everyday life of the care. There are collaboration gaps between the unit, between the organization. Even in the government organization, there are gaps of collaboration. So communities, initiative, facilitators can listen what is the opportunity, what is the obstacle, what is the pain point, and bring it together to come to collaboration together. This is also the initiative from the Patong Hat Yai that found that the communities have the gap between the transportation to go hospital, the gap of the social and healthy dietary for the elderly patients in communities. So they design the Patong Smart Care app and caring for the transportation, for the caregiving and dietary. The initiative training for the volunteers, carers, and connect together with the local government and local primary care unit. So there are work more alliance with the many units, many various stakeholders come to work together to do the caring ecosystem in their tambon. This is also benefits from the compassionate communities. They bring the youth, citizens, children come together with the elderly care. So the elderly care could include other peoples, include children to their communities. This program brings students that interested in the healthcare college. They train students to do physical falling risk evaluation risk, and bring the technique of the mental health to them, so the student can care to the elderly, can advise how to save more on the falling, and so a student can be part of the elderly care and palliative care in the futures. And the third component, there will be education and support benefit from compassionate communities. Like this, we guide community facilitators that interest in the mental health, listening, or bereavement care, or advanced care plan. They can set the tables and talk about palliative care, talk about death, grief, loss in their communities. So palliative care can go outside the clinic, outside the hospital, into the tables, some city festival, and talk about this. Is the part of the awareness, part of the community building and mobilization. Compassionate communities will encourage collective responsibility society, accompany each other to the educate more about end-of-life care, like a happy death day few years before, and death fest at the next month will also setting in this hall too. Death fest will bring together to talk about death, dying, bereavement, elderly care with the more creative way, and include also artist, also teacher, monk, various of the deaf education. And this is booth that that provide information and education patient in the circle of life. So we also teach about deaf education and literacy on the children and families. We bring artists and storyteller telling about the death, dying, bereaving issue with the artist performance. So they include all peoples come alive with the palliative care. So if you have compassionate communities in your areas, you can gain awareness, you can bring more resource alive with you and support more from communities. But the healthcare should open to communities, come to work together, collaborate together, share trust, share resource, share knowledge and space to work together and promote palliative care for all population. Thank you.
Thank you, Mr. Ekapop, for introduce us to the compassionate community concepts. End of life is everyone's responsibility. Everyone means everybody in the system, from policymakers to people, to family, and also medical professions. And some problems can be solved within community by their own context, which is good because Thailand is big. We have different backgrounds and culture, but some similar to Singapore. So I think we have learned a lot from all the speakers because of the timing, but I would like the audience to have the opportunity to ask one or two questions if there are any questions. Please come forward and ask questions. Otherwise, actually I have a lot of questions, but because of the timing, I don't want to take too much of your lunch time. I would like to conclude that everyone should have the right to live and die peacefully with dignity, no matter who they are and where they live. And I wish for it to happen globally, not only for Thailand or Singapore. And today, I would like to thank you all the speakers for their excellent talk. Please give them the applause. And also the organization and the audiences, I have to admit that the people in the room are more than I have expected. So thank you so much for joining. And thank you all the speakers. And I would like to conclude this session and then return the stage to the organization.
Okay, thank you very much, all of speakers and moderator. And now it's time for photo. A short while, please. ขอเรียนเชิญถ่ายภาพสักครู่หนึ่งนะคะด้านบน on the stage, please. Thank you. And the lunch is ready at banquet room. For the afternoon session will begin at 1 p.m. sharp. Thank you. Please enjoy your lunch.